Hi everyone, this is Lola. I'm the Harvard Site Coordinator for Mental Health Technology Transfer Center. Please feel free to introduce yourself in the chat box. And now I just want to go over a few housekeeping items before we get started. Next slide, please. So participant microphones will be muted at entry. If you have any questions during the event, please use the chat box. This session is being recorded and it will be emailed out to all participants once it becomes available. If you have questions after the session, please email newengland@mhttcnetwork.org. At the end of the month, we send out certificates of completion for any events you attended in the prior month, which you can then submit to your particular board for CE credit. If you have any questions about CEs, you can email ifisher@c4innovates.com. Next slide, please. This is an MHTTC acknowledgement. Next slide. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear and understandable, and lastly, consistent with our actions, policies, and products. And with that, I'll hand it over to Dr. Keshavan for introductions.
Thank you, Rola. And it's my pleasure and privilege to introduce today's speaker, Dr. Raul Condemarin. Dr. Condemarin is a psychiatrist at the Massachusetts Mental Health Center, and he is a psychiatrist as well as an internal medicine specialist. He founded and directed a medical center in Peru for tuberculosis patients in a town with a population of over 30,000 people. He did so for many years. And then he trained in the field of psychiatry and neurology, addiction, psychosomatic medicine, and he's also a diplomate in psychoanalysis. He also did a fellowship in HIV psychiatry. So he is as well-rounded as you can get with any psychiatrist. He's currently a faculty instructor in psychiatry at Harvard Medical School. He's on the editorial board of American Academy of Psychodynamic Psychiatry and wrote some papers on non-adherence and psychodynamic psychopharmacology. And that's the topic he will be speaking on, which is clinically very important for all of us to learn. And so Raul, please take it away. Looking forward to hearing your work.
Thank you, Kesh. Thank you so much. And thank you for the invitation. A special thanks for Raquel, Charlene, Lola, and Kesh for the invitation and facilitated my presentation for today. Before starting, I want to recognize and give a congratulations for the International Women's Day. Women's are coming from, my father died at my early age when I was 5 years old or so. I grew up mostly by my mom and my sisters, saying the number 8 from 9. But women, I always impressed with women's able to do everything. Big mom, professionals, the best friends and people could have, no? Our grandma, mom, friends, women friends, they are so special. Today we're gonna do the topic of non-adherence, which is a difficult subject, and I think women are the only one who could have the solution for this, no? Because they have this special touch who make our clients to improve, to help, and it's together, I think it's made the work better for all of us. I want to divide the presentation. I hope the time can help in 3 parts. One is going to be in terms of the introduction and just to review some numbers and some ideas about what is the problem with non-adherence today. The second part is just focus a little bit in the psychological issues behind non-adherence and what can we do here or any place with tremendous staff that we have is psychologists, social workers. And the last part is basically, I put a title, optimal treatment. How can we do what other people try to do to address these issues, okay? Regarding the medication not adherence, as I mentioned, and Paige already said, is an important topic and is a difficult problem for in psychiatry especially. The problem with medication not adherence is not only in psychiatry, no, is you review the literature, there is issue with non-compliance for especially chronic diseases like hypertension, diabetes especially, and so many diseases, no? For instance, studies about ADHD, no? Especially in kids, the little ones, not range between 20 to 60 years old, to 68%. No, more so the percentage of not adherence are only 50%. Range between 30 to 65, but the majority have close to the 50. No, who said it's a big issue, especially with the more younger population. The issue with not adherence is a very complex issue. No, it's a very complex. It's psychosocial issues, put inside is a big problem, side effects, and individual and psychodynamic issues, no, in the family, especially when we work with children. In terms of, for instance, not adherence with schizophrenia, which is one of the main things. This morning, I think also last night, but this morning I remember saw in the news some issues they were presenting someone in the airplane. No, I think you see the news, like he was very agitated, trying to, during the plane. I don't know, but first things who come to my mind is like it could be somebody probably, I don't know, with some mental illness and have it probably not adherence. No, he was sent for some forensic psychiatric evaluation. No, with respect to not adherence, there is some progress, but not the progress we would like to have with these main big issues. No, people with poor adherence, especially with antipsychotic medication or people with bipolar disorder or schizoaffective disorder, is the risk of relapse. When the time for relapsing is higher in people who are not adherent. It's like 4 times higher than the people who are adherent to medications. No? And as I mentioned here, when they are not on medication or they relapse, could be something severe and dangerous. No? Like I mentioned, happened, I saw in the news. Here is an example briefly of how the not adherence is coming down. No? For instance, this is in general, not for people with chronic diseases. No, for 100% of the prescription prescribed, there is a decrease in 12% at the time the prescriptions have been filled, then 12% more after the prescription was taken, and the continuation become a problem. So from 100%, then only 47 or less continued, especially with chronic diseases. And our mental illness are chronic diseases. No, for that reason, it's important to consider this. One of the main issues in not adherence, I choose this subject to discuss today because it's very prevalent for us. We have multiple part of our team meetings, high risk review or so are for issues related to not adherence. Probably 6 to 8 months ago, one of our patients, but it was my patient, who was decompensated with hypomanic bipolar, was feeling good, stopped the medications, for a while disappeared. And then when they show him here, he was at Fengudin and he broke all the windows, no, at Mass Mental. No, things like this. Other people you see in the news who are having assaultive behavior, aggressive behavior. So it's a big problem. It's something we need to address. Now, one of the main issues is the not insight into the disorder, into the illnesses. And this is very similar, no? The no insight is very related with not adherence. And different studies in Africa, in India, here in Germany, another one I review in Qatar, have good system, a lot of money, and the problems are the same. No, this is important. Like we need to try to improve these people inside, or look ways to they get a little more insight and figure it out that the treatment is very important. No, and by improving the insight on with other measures, we can improve the medication adherence. Among the issues, there's many reasons for not adherence. No, one is side effects. One is forgot to take the medication. Different inconvenience. And one big one, like if we could do something, is the pill overload. We have we as a doctor here, we need to be signing all the medications ordered, especially for the group home. And we realize like usually we have the first 2 pages are for medications. So we need to, the first pages is probably 2 pages just for medication. So that means one day I counted between psych, medical meds and other things over the counter, 25 for one client. The other is, but it's an average between, the minimum could be 4 or 5, and average could be up to even 10, okay? So it's pill overload could be, it's overwhelming too. So one important thing is we're gonna talk more about later, is the importance of the therapeutic alliance, no? That is very important, to have a very therapeutic alliance with our clients, no? But it's something that we need to construct. It's something like we need to do it little by little by caring for them, but be with them. It's nothing like we're gonna get with a few sessions. We need to remember the problem to do not fail to respond to medication is multifactorial, no? From problematic defense mechanisms, they don't mention have alcohol issues, other drugs, no, other that make a case in terms of not adherence, no? So the only way to improve things is a kind of supportive therapeutic alliance, no, was mentioned in 2014 by Kaplan. No, the therapeutic alliance is the most important. No, and therapeutic alliance not only the doctor, there is any of us provided with the clients. No, another study from Dr. Alfonso, who is now the president of the World Psychotherapy Association, mentioned about the strong importance of the psychotherapy and medication to the patient in terms of relationship. In terms of case, the specialist in this, but I put it this because one of the main issues in terms of the younger population, no? The younger population, the people who are in the first episode of psychosis, no? If there is not a social and family support, no? It's a big problem. People who have the tendency to reject the medication, no? They have it's another risk factor for not adherence in the future. No, I remember very clearly this case because when I started the Mass Mental, I was working in the PrEP program with Dr. Siemens when we started the program like 20-something years ago. No, and many of the discussion was this, no, the not adherence, And the old building, and the third floor, we put it a kind of a basketball and trying to throw balls with them and like playing basketball or throwing balls, talking about something, no, in different ways, trying to make it easier for them, no, to try to, they don't see like the prescribers, the one who, the bad guys, to make a better relationship. This one, I put it on purpose, sorry, it's cannot see really well, but it's basically the risk factors, no, for not adherence. This is the one we know the most. Side effects, people complain a lot about side effects. Other people about the cost of medication, they forget often. They don't want to be dependent. They don't know, they're not clear about if it is beneficial or not, no? And on, different, don't understand the instructions. Sometimes they tell take it 1 in the morning, 2 at night, and they take it in different ways, and they feel more sedated, tired. But the idea with these slides is like there is many risk factors, but it's nothing much in terms of the psychological reason behind this, the not adherence. No, this is the one like I would like to talk a little more, okay? Because forgetfulness, we could do something with alarm, side effects, we could do something like this, but the psychological things, there could be a problem. This is an old slide that I put on purpose, no? Speaking another factors for medication adherence. There are people who come in, we receive refugees, people coming from Africa, so have different ideas about medication, that can have an impact on medication adherence. They are not used to take too many medications, illicit drugs. But in here, years ago, this is from probably 10 years ago or so, they got cannabis use. No? It's like they put here like a direct factor for not adherence. Something like we hear often something like we hear very often in the office is like people come and said, I use marijuana daily. I don't like medication. I don't want medication who make me hungry. And I don't want to take the medication every day. You have something, I am open to take it. Who is so difficult? You know, cannabis is legal now. Here, people said it's legal, it's good, it's this. No, so we need to know how to live with this now. No, rather than pass from a no use, who is impossible, to know to less amount probably, to use it when they feel more anxious, for sleeping, for different ways, no? And also be clear, is cannabis an K2 or something different, no? Like sometimes people use it indistinctly, cannabis or OK2, which look very similar. At this time, I think we're okay with the time. Sorry if I'm rushing a little bit, but the idea is like I try to go to take the 3 parts of the presentation. This is here, I'm gonna try to present about the psychological and psychodynamic reason for the not adherence. No, it's something like we know, but we don't talk too much. It's something like takes a little more time, more expertise, but since we have many good people, no, social workers, psychologists, ACCS, and all the staff, like we work together to have in consideration this, okay? So once again, there is not any single risk factor for not adherence, but we can divide it in general. There's patient-related, medication-related, and provider-related risk factors. No, just to put it there. In terms of the patient, one more time, is the younger, the most possible for not adherence, low level of education, cognitive impairment. We have too many clients with very low IQ. very, very low IQ. Very often we see that, no? Who do not understand really well the instructions. We don't have the time to present it really well, no? That's something we need to have in consideration. And another big issue, like I want to go after a little more, is the comorbid substance abuse, no? Who is so prevalent. We have the typical client is the one who have here más mental, no? A young guy in between the 20 to 30 years old or 35 with history of schizophrenia, schizoaffective disorder, bipolar disorder, plus comorbid depression, anxiety, and polysubstance abuse. Marijuana, cocaine, alcohol, no? And not adherence to treatment, no? Among the, sometimes we have, you inherit a client who is 40 years old, and you don't wanna go too much into what happened during childhood, or you see wherever it is now, but last week, yeah, I think I went to the therapist's office to do a phone call for the client, and the client was complaining of having a kind of intrusive thought and feeling a kind of panicky. And I told him he has history. He's a 58 years old or so, no? He has more so adherence to medication for so many years to mass mental, but he has history of diabetes, and the diabetes sometimes well controlled. But one of the thing I thought, no, taking advantage of my training in medicine too, like could be a problem with hypoglycemia, because he was describing feeling like anxious, sweating, this sweat, anxious, like something want to happen, a kind of panicky, no? I thought could be that, no? And I said, this is one of the possibility, and the other one could be a real panic attack for different reasons. Because I think it's not related to this. I think it's more psychological. This is happen from time to time. This is from my childhood. This traumatic issue during my childhood. He's 58, 59, and he's remembering all this stuff, no? And he was clear. He said, no, it's a good idea, the hypoglycemia, but it's not. It's related to that. This happened to me before. So it's important, like, if we know this connection about early childhood trauma with not adherence, especially, or other symptoms they can present from time to time. It is important to people with not adhering or resistant to care, no? Many times have issues with post-traumatic stress disorder and other comorbid anxiety, depression, other things, okay? The patient with not adherence will be very important to check this psychodynamic determinant, no? To the response. So sometimes they have maladaptive defenses, no? They can contribute to not adherence. For instance, could be issues with denial, rationalization. They don't want to have a close relationship with the providers, no? They come just 5 minutes, 7, and they leaving all the time, no? And they don't give it a chance, and we notice this. And we just call sometimes, this is a guy of only a few words, but it's something more, okay? And sometimes they, no? Sometimes people feeling disrespected or infantilized by the physician, or sometimes they feel like the information we didn't pass is not correct, or something different, or we don't listen to them, okay? Regarding another issue is the attachment. One is trauma, one is the attachment. Many of our, especially talking, for instance, when I work here, I'm mass mental, no? And we have a big minority. We know the background of many of our clients, who they come from very dysfunctional families, no? come to my mind, for instance, a patient, like a new patient for us, like 3 years ago or 2 years ago, 2 years ago probably, who with history schizophrenia, paranoid, in denial for this. She was pregnant and delivered the baby at home in the bathtub. The test at the time of delivery was positive for cocaine. She said like people were cooking the cocaine and the drugs in her place, in her apartment, and that is the reason she inhaled it and became positive, but she was not using. This kid is in foster home. She's fighting to get it, probably get it, but we don't know. But those are the antecedents, for this kind of kid. Probably was the picture for our client, who is like 30 years old now. Probably was. And she had another kid before her who was now in foster home and like this. So we need to be mindful about these issues of the attachment. People with secure attachment, they respond different. More responsive to caregivers, when they are adult. But people with avoidant attachment, also called dismissive, they are emotionally unresponsive. They don't want to have a good relationship with no one, especially with us, with our strangers. And we see it in our case, me as a doctor, who need to see every 2 months, 3 months. It's difficult to make a relationship, but the therapists probably they have a better position, to establish. And many times, especially here, like we have good people, they do this, but takes time, but they do it, People want, but we need to realize, we need to figure it out. There is, in this patient, there is history of trauma, there is attachment issues, we need to see. So these people with attachment issues, we know some by the family history, but also the presentation is self-reliance, and they have this difficulty to trust it in others. And they are well known for not adherence. If they don't trust it, close friends or family, they don't want to trust it to us or me, who just know him and want to offer an injection today or something. So they listen, yes, and mentally they say like, I don't want to do this. But basically there is poor trusted relations with the other. What is the therapeutic implication for this? Okay, in this area, I was talking mostly about this issue, the psychological things. Like it usually happen in early childhood, attachment issues, trauma. The important is to have this awareness about these attachment issues. The so-called dismissing attachment. Also, it's important to have in consideration, because when we do our treatment plan and we reframe our psychotherapeutic work, we need to have in consideration this. It's not like a group home, they program this and that, so simple and schedule, it's not gonna work. So we need to know. These people with dismissal, you say, okay, they program here, there, you go to over here, there. They don't wanna go. They have dismissing attachment. So they don't wanna be close to no one. They don't trust, they wanna be alone, so they wanna be home alone. So we need to see, otherwise our plans, our treatment plan is not gonna work. Okay? So it's important when we do our plans, we need to try to be clear about the contribution of the attachment theory, in terms of these issues, especially in terms of not adherence. And looking for the importance of a collaborative relationship with the client, with the other as a group, trying to work as a team with the goal of promoting trust, a better relationship with our clients. Another thing I want to mention is, I think I have 15 minutes or more, 15 minutes, about the trauma. Now people are talking more a cumulative trauma, not like a trauma that happened 10 years ago, 30 years ago. It's accumulative, it's something, re-trauma in different ways. They start in childhood, they do in the adolescent, they some start moving to a new relationship which is traumatic for them. So it's a cumulative trauma, no? And there is a, no, like I mentioned here, this polytraumatization, no? There is a very well-known link between trauma experience and substance abuse. Could be very simple, why they use drugs, or they will say, why you use marijuana, why do you drink, why you use cocaine? Like it could be too simple, no? But this is a big link for them. No, we need to know. Even they deny it or no, we need to look for this. Like when you do internal medicine or medicine and somebody said, like, I don't know, is taking antipsychotic medication, second generation, no? And also they complain of feel hungry, they are increasing weight, they are feeling so thirsty, urinating more. So you be suspicious about diabetes or hyperglycemia. No, the same with the history of trauma. If you look for substance abuse, probably you want to find it. But so they want to help us what to do. Like it's not a simple problem. Okay, this survey with adolescents mentioned about the prevalences to 30 and to up to 87% of substance abuse in patients with trauma. So if somebody with a clear trauma history, you go look for substance abuse, you want to find it. But not like using once in a blue moon is something more in terms of the abuse. No, people who have PTSD, they have the same, no, the 37 to 52 percentage. No, it's very important also when we send them for any treatment or we start any treatment, psychotherapeutic with the patient with terms of substance abuse or so, to really be careful, no, when we try this, because sometimes by addressing these issues of trauma, so sometimes can induce, or at some point can induce increased anxiety, anger, depression, and the way the symptoms they had before, and the way they cure their symptoms, like they said, I cure this, is by drinking, by using something like that. If they feel rather down, they use a kind of cocaine. If they feel like too hyper, they use the cannabis. No, they feel this, or they drink because they feel happy, they can laugh, they feel like people love them. They have like it's the time like it don't feel like it too anxious being close to other people. So we need to be this. Sometimes we send it. Some people told me sometimes I want to send it to any program for alcohol or so, and so many times they say no, please don't send me to any of these places. Why? No, I don't want to hear about nothing about this. First of all, they talk about alcohol the whole day and make me more anxious. I don't know what to do. Or sometimes they talk about the factors why people drinking and remind me of my childhood. And now I'm drinking even more than before. So we need to know. So like always I said, it's like a construction work. Before doing this, we need to have good foundations before start digging too much. No? And this is very important. Somebody quote this, the importance of the deep root between connection between trauma, mental health, and addiction. This triad is very common, no? And is a deep rooted, like they mentioned. In terms of the doctors, the prescribers, or anyone could do therapy or so, is sometimes, in this case, talking about a psychiatrist, a failure of empathy. Like we just presented without looking at them and not with not sensitivity, not being responsive to their needs. No? Speaking just to what happened 2 weeks ago, I saw a patient who was probably tried in 3 months, like 5 different antipsychotics, because he take it for 1 day and call it and stops. He said side effects. Not even after taking is complaining about the side effects. No, and we give it one, the other one, like this, until the group home was calling me for another medication. So I said, I don't want to prescribe anything, no, until he's more ready. So I called the client. No, he came and said, I don't want to prescribe anything. By the way, the client has a schizoaffective bipolar type, a smart guy. And I said, what can I help you? How? Tell me some ideas about what kind of treatment would you like to get, no? It makes sense, we do it, no? So more than the symptoms, like a headache, constipation, voices, and one medication for each one, I say like, we want to put together in one, no? And we try to use the less medication possible, only one, something that you like and I want. And he said, I like, he said something like silo. Do you know? I said, I know it. He was looking for psilocybin, no, it's a psychedelic drug, but I pretend like I didn't know. Say, no. Psilocybin. Yeah, he said, yeah, I got it, psilocybin. Yeah, and he said, you know, this is a good medication. My dad told me like to tell you like this is a good med for me. Your dad told you that? Yeah, says, and then he said, you know, I am tired. He became more open. So tell me about more this. He said, I am so tired that, he said, I'm a white man. Being white is so important in this country. Said, yeah, you're right. But white without money is no big deal neither. No, but white with money, you doing whatever you want. My friends who have more money than me, they buy whatever, and I'm tired to be saving my money and spend it getting mushrooms in the street, getting this. I'm tired, not have no money. So what's for me an opening? I was listening. I was not judgmental. I was just listening, but wasn't open. It's something never disclosed to me. No, he likes more this kind of psychedelic kind of drugs. Was a choice. No, no. So, but good. We opened it. No, he felt good to finally tell me because he was an opportunity. He went to we were told like he was to the ER, so disoriented, disorganized, but he was discharged the same day. And nobody knew what happened. And now it started making sense, no? He used that. He was a kind of disoriented, hallucinated, and probably was in the emergency room, observation, and then the next day was out. But this is the idea, like to have empathy. To have empathy, to listen, can be so helpful to promote adherence. So I want to go a little higher, a little faster. One is want to talk about the optimal psychiatric treatment. I quote this like I saw in one of the titles of the psychiatric news from the editorial. They said optimal psychiatric treatment target the brain and avoid the body. No, basically the idea is that there is not this kind of treatment so far. Good idea to go directly to the brain, minimal side effects, and nothing happens with the body. We have the opposite, no? A lot of weight gain, a lot of side effects, fatigue, tiredness, so many things. There is way like if we can manage the side effects, we can check the lab test or so if they're taking a medication or not. But we are so far about this kind of medications, not who are perfect. Just I put this email basically. I want to pass quickly this. The idea is to work to mention about the treatment resistant. This is a new medication they call Ovelity. Ovelity is a new medication. Basically, it's a combination of dextromethorphan and bupropion. Okay, this is an old medication used for essence NMDA antagonist. But this medication is well known. Everybody probably took this medication for when you have cough, you feel cold or so. All the syrup have dextromethorphan and bupropion we know. But when we mix this medication, this dextromethorphan is a NMDA receptor antagonist. That's the reason why you took too much of this, or sometimes the kids years ago they were taking the syrup for the cough, no, and they need to take it from the OTC departments in the pharmacy because they're getting too much. This is the idea. It's very nice how this is bupropion, this is dextromethorphan. They work in the channels of the big receptor, the glutamate, to have subunit they call N-methyldopamine aspartate. Now, I say in this, which sounds really fancy and try to impress you with this, but the point is like, could be so nice, good medication, so many things, but they are not working. If they're not adherent, they don't want to take, they're not going to work. Something we are responding to the client is like, okay, you have, this is your medication, no? For the headache, for the voices, for the sleep, for the tremors, for the sedation, for the dry mouth, no? And those are the side effects potentially, you know? There is the main one, like a hyperprolactinemia, hyperinsulinemia, hypothyroidism. Like we can do something for that, no? And there is many, it's true, there is a lot of side effects from amenorrhea, confusion, hair loss, gynecomastia, but it's something like we can work on this. The point is like how we want to treat our clients, no? There is non-pharmacological is the psychotherapy. This is the idea we need to know the main symptoms of the client, what is going on, the history of trauma, attachment, and other issues, and we can improve the adherence with good psychotherapy. No, we can improve the coping skills, no, for them, improve the self-esteem, no. Another thing is in terms of net invasive neuromodulation, which basically go directly to the brain. But ECT is too traumatic. TMS is bilateral, it's a kind of ECT fancy form, but it's still not used on a daily basis. We cannot respond just with a lot of medication. We have injectable medication, which is something for not adherence. We have every 2 weeks, and the latest one for every 2 months, but not necessarily. Just they can fake. We have a visitor nurse, but they can be counting pills, but they can throw it. They can pretend that they are taking. It's hard, the problem with this. Something I want to talk briefly is about the motivational interviewing and motivational pharmacotherapy. Motivational pharmacotherapy is a kind of, they mix motivational interview with pharmacotherapy, and they put it together. So they try to listen to the client, try to see what is the goal of the client, what is the most important things. And this was done in New York, for the Latino population. The group of Columbia University, they have a big group of Puerto Rican and Dominicans, and they use a lot of cultural things. For instance, they have a 8 weeks program, and at the beginning, and the 4 week at the week 4 and the week 8, they work about issues about side effects, other issues. They give it, for instance, they recognize issues about the cultural syndromes. For Latinos, very important, the nerves. Just by saying I have problems with my nerves is a lot. So we need to understand this. And also they give it like a kind of holidays. For the Latinos, very important. They want a time for the nerves adjust by their own. So all these things were important. This motivational pharmacotherapy, the motivational pharmacotherapy basically mix motivational interviewing techniques with pharmacotherapy. It's something go together. They is trying to avoid this right and wrong. It's more personalized, and they share the decision-making things. They empower the patient. The idea basically is to try to give the client a little more power and participate really well. For instance, something like I doing here often is people complain often about feeling so hungry and increasing weight. And they go to the primary care and say, your glucose is 70 is 5. They don't check more or they don't check anything. For instance, I check in here, the insulin level. It's very common before along with hyperglycemia, the body responds with releasing a lot of insulin. The levels you see here is 2 to 19. This person have 82. So that is the reason they feel so hungry all the time, So I cannot respond only like, don't eat Doritos, take water. No, there is something going on. So we need to, we need to do it as a doctor. We need to check other things. This is another patient. That one, the prior one is from 2016. I have lab from 2003, like I showed these problems. And this is from recently, no, 22, no, December, no, 98. There another patient who's feeling too hungry and doesn't want to stop the medication. One of the things try to finish is it's very important at the time of prescribing or at the time they do the services. It's not important how. The most important is how we prescribe more sometimes than what we prescribe in terms of medication experience. So we need to prescribe in a nurtured way, familiar, collaborative. Look at this picture, no? Like if they're having good time, they understand each other. Patients want to take this, whatever you offer, aspirin or anything. We can offer the other medication, like the fancy one that I mentioned too, about the depression. But if you say, okay, take this, and you have aspirin, no, it's new for me too. They don't want to take it. No, stuff like this. So to finish, and it's important to have the trust of the patient. No, they said, hey, it's time to make this, and take just 1 minute to break it. You know, they are so sensitive, so many things, so it's important. And I want to just to say that in here, there is a good examples and people who devote their life to here on Mass Mental, and they do a wonderful job with our clients, no? They develop this trust. They even sometimes prescribe something and said, hey, I wanna talk to my therapist to see what she said. And it's fine, no? Because they talks about their relationship. Or sometimes the therapist said, hey, I said to the therapist, doesn't want to take the medication. Don't worry, I want to call him. And they say, yeah, she's ready. This is the one that we need to have, to work together, to help each other, and to get this, the trust, and make all these good medication that we have now to work. Thank you. Open for any questions.
I have a question. Thank you so much, Dr. Condemarin. This is really helpful. I think this probably happens a lot with many of our patients, where sometimes because of the very factors you described that cause the non-adherence, someone decompensates to a point where either the therapist or the psychiatrist needs to send a section 12. And in I'm going through this currently, and it has really negatively impacted the relationship. And I'm thinking now how to rebuild the relationship and rebuild the trust to try to establish that foundation to encourage the person to continue on their medications once they leave the hospital. But it's been almost 2.5 years of relationship building threatened now because of this breach of trust. So what do you do in those situations? What do you advise us?
Yeah, I think this slide, Amy, said like this, no, takes a lot of time to make it and 1 minute to break it, no? And come to our mind all the time with the section 12, we just, with the therapy, we did the section 35, but sometimes we need to do it, no? Because there is a point like they are danger to self, others, and just to preserve the relationship, something can happen to others in 1 minute. They live in group homes, they take planes like this guy we saw in the news, and things big happen. So we need to take this, but something like probably other therapists who have so many years, like me here, Dr. Cage, and we do it, but the relationship is there. They are upset with us, but after a while, they forgot about it. No, I remember I recently, just for different reasons, couldn't see a client, and I said, I saw it, and I said, what's the section 12? I said, so sorry, I missed you the other day, have a big meeting, I couldn't there. And he said in Spanish, this is an old love we know for 20-something years. Don't worry, okay? I knew it, something was going on. Of course, I was upset like you wasn't there, or you were in a meeting, I was waiting, but he said in his own words, it's an old love. No, but it's something they remember, and little by little, and we need to go. They're like a little kids. Like we need to go, and is like hidden, and then one day they put it back, all the work, bring it back to the picture. But the things you remember, no, like these attachment issues, the trauma issues, they feel like you are one more person who betrayed them. But we need to say like, if the mother wasn't there or someone wasn't there because was using or something, in your case, we doing to preserve him. And sometimes when you're in the hospital, you felt much better. Now you are living there, you're taking care of your kids or whatever. They sooner or later they want to see it, but takes a time. Takes a time to build again. But the savings are there, like a luck, but after a while they open and they give it to you back.
So Raul, thank you very much for a wonderful, elucidation of the importance of the therapeutic alliance in improving adherence. Now, the one question I want to ask you is about the long-acting injections. They come in multiple preparations, which can be given either every 2 weeks or every month or every 2 months or every 3 months or every 6 months.
Yeah.
Now, one issue with the longer frequencies of these, like giving every 6 months or every 3 months, would mean the frequency with which they see the doctor goes down. So do you have any thoughts on what is the sweet spot? What is the right frequency of long-acting injectables?
Thank you for the question, Kesh. It's a very important question and sounds like a very nice, to have every 6 months. But something like I noticed our client, for instance, to come weekly, bi-weekly or monthly for the clozapine and doing for years become a kind of routine for them. No, they come and sit down here at the second house or the first house, no, and become part of the routine and the environment. They feel comfortable. Usually, when I try to, if they are not unhappy with the monthly, I prefer the monthly because there is different eyes from in this case, the canoid clinic, other people who see it and can give it a little feedback. No, sometimes when just very established a relationship, they are very more so stable, and some family support or people who are behind and move to every 3 months. Ideally, at the beginning, I was try to see it like after the second month and the third month when they come here, somebody can see him. The 6 months is really good idea, but I think it could be too far. It's difficult to see really what is going on. That could be good for people who are who are really stable. There is some people who are really stable, who are working for years. One is working in TMX and hard to tell they have any more residual symptoms. No, those are the ones probably could benefit. But I think I use more in emergency basis for people who I know the adherence is not going to be too good. And when they judge or anyone call me, there is something in the system. But ideally, in terms of that we talk today, a more close relationship and to be involved with something will be ideally no more than 3 months, ideally. And the 6 months is basically...
I agree with you. Thank you very much for that impression. The second question I want to ask you is about what does one do with people who have a lack of insight, not because of denial, but because of the disease itself, that they cannot appreciate the nature of the illness because of the anosognosia, which is basically a neurological problem. How does one address that? What I have read is that they could be, they could benefit from a specific form of cognitive remediation, metacognitive training. Do you have any experience with that? So basically, it's a form of cognitive behavior therapy or cognitive remediation, which focuses on thinking about thinking. Thinking about, giving them stories of other people with schizophrenia and having non-adherence and relapsing, and ask them, what would you advise this person if you were trying to help that person? And they'll say, of course, I will encourage them to take their medication. But then you twist it and say, ask them, what about if it were you? Then the whole thing breaks down. So it requires a training of the metacognition to apply situations.
Yeah. No, I remember your program, the cognitive remediation, and I sent some clients in the past with when you were with Rosa at the group. And what's very important is, we need to everybody work on that because it's a big issue. It's a big issue. It's nothing simple, no. But something like I have some patients who have very poor insight into the schizophrenia, but they were loving to take the Adderall. And they were calling now because sometimes they said, I want to work. I was taking Adderall when I was in high school and was doing so good. And not just sometimes make no sense, but low dose, giving low dose. But I was so surprised how they call every 25 days or so, even 3 days before the date, around the clock, no? Yeah. Because probably they find something with this, no? I heard in the news like there is a shortage of Ozempic. It's a medication for diabetes, but they don't focus too much on diabetes. Especially women are more happy because they are losing weight, and finally something is helping to lose weight, and this is Ozempic, no? So in some ways, so the idea was for diabetes, but they're more focused on something. I don't know if we distracted them and focused on something that they could like, they can start gaining probably with the treatment, improve a little bit the insight, because otherwise it could be so difficult. But my hope is by being medicated, not always, with medication, sometimes they gain some insight, or at least they got in the routine to do it. In addition of the no insight, the poor insight is the low IQ of our clients who make the picture a little more difficult.
Yes. So I think we are at almost 1 o'clock. Does anyone have a question? Any one or two more questions we can before in the next couple of minutes?
Question, comments?
I have a question. It's a little bit out of the blues, but when we're talking about all these treatments, and you mentioned that one of your patients mentioned psilocybin.
Yeah.
I wonder if in Mass Mental, there is any space for clients to engage in those studies that are being made in Boston about those therapies like psilocybin and MDMA for like depression resistant to treatment and PTSD. How do we deal with that?
There is many things who are more experimental. No, I think that the researchers, they're trying to become more open to try different things. Like one of the big challenge we have is to treat our patients with any psychotropic medication along with cannabis, along with low drinking a little bit. Because this is what is going on. All these, our probably 99% use cannabis, no? Different amounts. And it's something like this. Oregon have some open, no, to this study. It's not for everybody. And that is the reason there is not conclusive studies like they need to, they said could be, it's not for everybody, first thing. Second, in conjunction with therapy altogether, for a special group, but it's something like we need to be open. If it's someone who have the criteria for this, no, could be more open, no, or for the same for the use of ketamine or this new medication with oral. But it's something like I think it's probably to finish is the message is like how we can be open to do some stuff. Dr. Keisha's group do a lot of creative good, like a cognitive remediation. They have a kind of a machine they good practicing on this, and they doing some tests. No, it's something like we need to try to see how, because just the typical in the office, you come and they give you the Haldol or the injection, doesn't work immediately. We need to be more creative. That is the reason I presented today this motivational pharmacotherapy. Could they mix it, the motivational interview with the therapy, and in the cultural environment for Latino, thinking about the nerves, thinking about the drug holidays, like the Mother's Day, don't take the medication, my husband party, Latino big party, so don't take it, something like this, no? Rather than no, Sam, you could do it this day. Do something. Open. We need to do it because it's if it's anyone who is an art, is psychiatry. Because in emergency, there is just ABCD, and here could be CAB, DAA, and berries. Cash could be 25 seroquel, I need to use 1,000. They love cash, they hate me, whatever it is, or the opposite. No, this is art. You have to have a lot of knowledge, but also you need to know how to present this. So like you need to be the composer and the singer, both, to make the picture a little more difficult.
Dr. Condemarin.
Yep.
Hi. I'm Leo. I work with Dr. Condemarin very much, but that doesn't make me a disciple, hardly a disciple. But Dr. Condemarin, your last slide, you said how we prescribe versus what. And I remember a couple of weeks ago, I don't know, because I had to step away from the presentation, but did you, do you remember what you said a couple of weeks ago to me and one of the residents? Dr. Condemarin, you said, we are the placebo. Do you remember?
Okay, yeah. It's true. It's true. As it Kesh and other people, we are not only the doctors, but the psychologists, ACCS, nurses, BNA, we are the placebo. We can make the medication work better. Galeno, 300 years ago, was doing medication with probably placebo, but this. It is that you want to see something that if I don't work, I want to send you to the 6th floor. This Dr. Keshevan, who is president of everything, he knows everything, the director of Harvard. Okay, send me to this guy. He knows this, he knows experience, he can listen. It's like this. No, so that helps a lot. So this is a power. If we use this power really good, like they said, okay, give me this. Or the restaurant is so expensive. Supposedly it's good because it's too expensive. And like this, no? So we need to use different ways. But I think it's came to my mind like be like Amy mentioned about the trusting relationship, the how to prescribe rather than what to prescribe. Because I think Kesh was working with years ago with Haldol and doing good job with Haldol, and is having fancy medication and not necessarily doing better job, no? Or did a good job with difficult patients with just Haldol or Prolixin years ago, no? But it was the how he prescribed, how he was there, how he was looking, they make the difference. I think that this is the message. How we do our services make the difference.
That was a very nice presentation, Dr. Condemarin. You're very easy to listen to and get the message from.
Thank you. Thank you so much.
Thank you so much for attending, everyone. I've pasted the post-event survey in the chat, and I'll also send it out via email. Thank you.
Thank you.